This program is brought to you by Emory University.
Good morning, everyone. Sorry for a little bit of a late start. Chris had to save us here with our live stream. But good morning and welcome to Heart and Vascular Grand Rounds. This morning we have a real treat with us for you today. Dr. Peter Wilson is going to be our speaker, and many of you know Peter, hopefully personally and by reputation. He's literally one of the world's authorities on lipid management. Peter, as you probably also know, is by training an endocrinologist, even though we've stolen him to cardiology. Peter was a critical member of the Framingham group and had a long time there with great publications that really helped set a lot of the way we practice and appreciate preventive cardiology and cardiology in general. He's been at Emory for quite a few years. His publications are absolutely enormous, probably over 400 or so at this point. He's a frequent recipient in the Millipub Club with multiple publications with over 1,000 citations. Has had leadership roles, throughout all of our professional societies, American Heart, American Lipidology, et cetera. His is currently based at the VA, where he has a major role in the Million Veterans Program, and he's going to explain this all to us, tell us how to do this easily, straightforward, clear all of the confusion about lipid guidelines, and tell us how to do this properly, right, Peter?
Okay. I have no disclosures. It's Monday morning, so we start off easy, so come on. So let's go for this. Would you pick this up? So I think you can with a good photo, and you know what you're looking for. You're looking at the person's eyes, and you're looking at the intercanthal fold, and you see yellow deposits. So they're yellow. Greek for yellow is xanth or xanth. So these are xanthelasmas. If you called them xanthomas around the eye, you couldn't remember the other special word, that's okay too. They often get removed. We have a patient at the VA who keeps having them come back despite therapy, and he gets the plastic surgeons to remove them outside the VA. So also think to ask whether the person's ever had any yellow deposits in root. By far the most common, there are a couple of esoteric causes in lipidology, but by far the most common is xanthelasma because of FH, familial hypercholesterolemia. Now these are the widest Achilles tendons. I was thinking about replacing this photo. This is from a patient at NIH with homozygous, the double dose of hypercholesterolemia. But get used to feeling the Achilles tendons. Your patients with FH are going to have thicker Achilles tendons, and if you've got a child in the office, reach down and feel the child's Achilles tendons too. It's one of the more, I want to say, easy things to pick up. And most adults who are not severe, most of the stigmata or the clinical findings really go more with homozygous than heterozygous. So your 50-year-old patient with moderately high is going to have a thicker Achilles tendon. And get used to comparing them to yourself. For instance, I have a pretty sharp one. The fellows, I always have them reach down. I said, you probably have the sharpest one in the room, and it really comes to a knife edge. So get used to thinking about it, though. Okay. Now, knuckles, anything where you have tendons, you can get xanthomas. By far, they go more towards colder parts of your body. So the hands, but you got hands, you got a lot of blood flow. And get used to feeling them. I always say, when you're feeling for a xanthoma, close your eyes and then try to feel it move and get used to what it's not. It's not a rheumatoid nodule. You know, it's not a syndesmophyte, for instance, people who play instruments and things like that or work a lot with knitting, or it's not osteoarthritis. And then along the elbows, get used to thinking there, you may see a big xanthoma there. And we used to have rheumatoid nodules there, but those have sort of, rheumatologists have removed those from us. And it's not gout, but though you can get them, they're not usually as big as what you would see with RA or with gout, though. So those two, and a little bit on the knees, but not so common. Now this is Arcus corneae. We used to call it Arcus senilis. But it can come on at a fairly young age. It comes on earlier with people with darker pigmentation and people out in sun. Workers in sandy, bright areas, workers on water, for instance, fishermen, they'll get it earlier. And it's probably helpful up to around age 25, 30. And it really fades quite fast for people with dark pigmentation after that, maybe up to 35 or 40 for people with light skin. But it's a soft finding. And there are a lot of other things that can cause this or can look like it, and you don't always get a full ring. You can get a partial ring. So it goes down the list. Wilson's disease, hypercalcemia, homocysteine elevations, goes on. But at least think to look at it for especially younger patients. Okay. Now, this is the one slide I'm going to just quickly go through for hypercholesterolemia. So we have two versions of this. We have heterozygous and homozygous. The previous estimate for heterozygous was 1 in 500. It's now been pushed down to more in 1 in 250, and in some parts of the world, 1 in 150. As you can see, some of these, the genetic areas I mentioned in that third part there, some of the Mediterranean regions, some of the Dutch areas, some of South Africa where Dutch migrants have gone. I mentioned the findings, but the key thing is increased LDL cholesterol and the protein that goes with that, which is apolipoprotein B. You can do molecular diagnosis. You can go through a variety of the groups. Most of us feel you don't need to do that, but there definitely is some element of a push. So let's say a father has heterozygous and the child is borderline high and he's 15 years old. Some physician may say, well, let's go ahead and get the genetic diagnosis. It might motivate you as a parent or as a clinician to be more aggressive with that child. And over and above the cholesterol level or the LDL cholesterol level, the genetics may play a role. But it really, you're making the diagnosis on the basis of the lipids, and you don't really need to go that extra step to get the genetics. Now, you might have some genetic testing, of course, for if you had 2 heterozygotes, that would be the most common still, and that's rare. So 2 heterozygotes are planning a family, and they're not sure they really want to have a child with a homozygous condition. You could test for that. But mind you, now homozygotes are doing quite well. The average survivorship when I was in training for homozygote was none of them made it to age 20. Now the average lifespan is 35 years age. And they're getting everything under the sun right from the word go. So the medicines, as you can see down in here at the bottom, are all the usual medicines. You start with the simplest ones and diets and things, especially starting after 3 or 4 years old, so that you've had enough lipids in the system for full brain development, and then they move on to the other medications. Historically, one of the most famous procedures ever done for a homozygote was simultaneous heart-liver transplant by Frank Starkel, I think that's right. Spencer will correct me. The fellow from, what was it? Starzl, thanks. So at Pittsburgh, for one of the patients from Dallas, and then the patient went on immunotherapy and unfortunately died of a cardiomyopathy quickly over a weekend. So, but now we've moved into these newer medicines, and mind you, the typical thing that they're going to be on is going to be a statin plus quickly a ezetimibe and then PCSK9. And then if they don't respond to that, another alternative, such as Larry Sperling who was here, we have apheresis. Apheresis is generally for people who are homozygotes, but it can be also the most severe heterozygotes. And the target there is to really reduce their atherosclerotic burden as soon as they are old enough and able enough to get the regular pheresis. Now, for instance, here in Atlanta, we have one pheresis center. Various parts of the country have no pheresis centers, so this is a real challenge. And rising to the challenge has been the FH Foundation, trying to make awareness for clinicians and patients all around the country. So you can measure lots of different types of lipids. LDL cholesterol is probably the one to think about always when you go home today, but as you can see here, I'm going to show you this slide. Historically, what we measured over in the far right is total cholesterol. And a researcher would do ultracentrifugation, which takes historically 24 hours, now more rapid. And you can separate the different particles by densities using a sucrose gradient. But nobody had time and money to do that, so they started doing other ways and precipitating out. So one of them, you precipitate the top parts out, and you can then measure what's left, and that's HDL cholesterol. And historically, you can also now precipitate the non-LDL parts, and you can measure LDL. There's also a Friedewald formula, which is an indirect way to take combinations of these, and the surrogate of VLDL is triglyceride by 5, using American units, and you estimate LDL cholesterol. And at very low cholesterol, you're now going to start to see an alternative to the Friedewald. Is Seth Martin at Hopkins has developed yet a new algorithm which varies this number basically to try to improve accuracy of very low LDL cholesterols, such as patients on PCSK9. Now, what counts? I would say most of these are a tie, and it's getting a little more problematic. What should I think about? Should I think about LDL cholesterol as historical, or should I do which is just total minus HDL, which is called non-HDL, not a great name, everybody agrees, or the apoprotein, which you don't have much experience with. And so you see the overall relative risks according to a lot of observational studies per, standard deviation type 1.24, 1.18, 1.43. This is from Alan Snyderman, who's been one of the major proponents for APOB. But most of us would say this is more similar than it is different, and maybe a little bit harder to sort out when we get to very low cholesterol, such as patients on most modern aggressive therapy, especially with known disease. I'll skip by this, but this is another example of things going beyond total cholesterol. Should I measure any of those? For instance, the LDL has a range of particle sizes. We used to talk about fluffy, puffy LDLs, which were not so atherogenic, versus hard, dense particles. That science has moved a little bit more towards LDL particle number, a greater particle number being more associated, and maybe even a little stronger than LDL cholesterol. But again, it's probably an extra step that's more in a researcher's hands than in typical clinical care. These other measures are mostly types of things to remind you, well, what's the difference when I measure fasting versus non-fasting? Fasting, you start to get non-fasting, you're going to get chylomicrons and you're going to get remnants. So if you had a heavy breakfast with a lot of fat, you say, how long should I wait even to measure lipids? Well, you're going to have trouble in understanding your LDL if you've used an indirect method. But your total minus your HDL works pretty well regardless of fasting. And it's your triglycerides that really get changed according to your fasting status. Should you measure LDLs or lipids in the afternoon? For sure you should measure them. Just recognize if you have, let's say, a 10 or a 20% slightly higher triglyceride or LDL than for usual for that patient, it may be because of the triglycerides. He was not fasting, or he just eaten lunch, or even the same thing for at 10 o'clock in the morning. I always say if the patient's there and it's convenient, go ahead and measure the lipids. Just get used to interpreting as whether they were fasting or not fasting. Now, this is a molecule of Lp(a). Lp(a) has in the center here in yellow an LDL core, and then it has these little loop-de-loops, which are called kringles. And the kringles are a protein, and that's apolipoprotein A. When do you measure this? Because you'll hear about this occasionally, too. The target has been historically persons with early coronary artery disease. And in the older American Heart Association statement, it was persons who had a heart attack at age 40. And it's still very reasonable. There's very little that lowers Lp(a). Niacin is about the strongest, but not really that great either. The PCSK9s have some greater effect than many of the other treatments. And that's one of the reasons you'll hear this at meetings. Oh, yeah, if the person has high Lp(a). Also, first of all, you have to think to measure it. Secondly, you have to think that maybe this patient's going to be a candidate for PCSK9. But we're not quite there yet. But this is not going to go away. And remember also, patients with increased Lp(a) have increased venous disease. So especially you have a 45, 50-year-old man, woman, with both heart disease and deep venous thrombosis, and possibly early heart disease and venous disease in the family, especially think of Lp(a). Okay, I'll skip by that one. That's most of what I just said, all right? Comparison of those two molecules. This is also, what do you do about risk, as you can see here? So here's LDL cholesterol going up from less than 100, and all with that's the comparator hazard ratio, 1.00, and as you see, going up to 220. What about Lp(a)? Once you already have the strata, you see an even bigger effect. And where Lp(a) may count is whether you sort of handicap it depending upon the starting LDL cholesterol. So if you have a high Lp(a), but you have a normal LDL cholesterol, it really may not be quite so important. You have your patient in front of you, and you're now trying to get into the dietary discussion of your advice. So what do you tell the patient? You should eat less fat, especially the saturated fat. And the fat that's saturated fat is the fat that's solid at room temperature. A few things, I just try to say things that you can remember and you can translate to patients. The gooier and chewier cookies generally have more fat. Some of the highest fat, of course, was taken out of cookies, but it's still there, and they keep switching to other types of fat. So the palmitic types of fat, the stearic, other types of things which really increase shelf life are not necessarily the healthiest. You encourage the patient to have more polyfat. And not on this, but related is what about partially hydrogenated fat, which is in the margarines and other dairy products. So you want to encourage them to be careful about those. When in doubt, use liquid oils. They're generally healthier, more than the others. One other question comes up is the patient will say, well, how much, if I really work on my diet, how much am I going to get lowering? And the range is generally 5 to 15%. And you're going to say, in the modern era, well, ho-hum, I'm not very excited. 5 to 15%. But it does have a major effect. And any of our patients who have very high lipids, you're going to be encouraging this for the entire family. So we don't want just you alone to be thinking of how a prudent diet. We want you to have the whole family. Now, do you notice what's not there? Cholesterol's not on this. So cholesterol intake has slowly been pushed off the major determinants of LDL cholesterol. If you go to major guidelines, you won't see strong statements. I want to say it's neutral to not so important. But 20 years, 30 years ago, we used to say, oh, yeah, you really should only have eggs on the weekend, that sort of statement. We don't need to say that so much anymore. It's all the other things that you might have with eggs, and especially breakfast foods that are high in fat, to be concerned about. Now, the other side, HDL, which is a realm in which we've tried to have medications such as the cholesterol ester transfer protein, the CETP molecules. This is largely a lifestyle. And you want to encourage people, because your only efforts really going to maybe translate into preventive cardiology are the determinants related to lifestyle. Generally, the healthiest people with the highest HDLs are exercising women who are thin. That's unfortunate for us as guys. But so as you can see there on the right side, a woman who's thin, no cigarettes, has a little bit of alcohol intake, she's exercising, and she is going to have, now there's a little bit, if she has a little more saturated fat, that actually might help her for HDL, but we wouldn't encourage that. And of course, she may have some genetic propensity. The major determinant probably for most of us is obesity. And then secondly is going to be exercise, and aerobic exercise will especially increase your HDL. So a couple of rules of thumb. So the average HDL for a man is around 45. For a male jogger, it's around 55. For a male marathoner, it's around 65. And then once men start getting over 65 or 70, it's starting to become especially genetic, and or the person's an alcoholic. So you should be aware of that. CETP, especially in Asians as a genetic variant, is maybe one of the more common ones. For women, 55 is the average, 65 in women who are exercising heavily, and then into the 70s, and you don't see much above that for the women. What about diabetes and lipids? Or is that a fruitful place? And it probably is one of the most fruitful to find patients with abnormal lipids. This is an older comparison for Framingham, individuals' lipid extremes among diabetics and non-diabetics. As you can see, they're high triglycerides, low HDL, high triglycerides, and low HDL alone. These are patients often have the metabolic syndrome in addition to diabetes. But one of the things is to note what's not so different is their total cholesterols and their LDL elevations are not that different. It's mostly triglyceride and HDL. And this is men, and in fact, it's more acute, the differences diabetic versus non-diabetic in women. This is how women especially get premature atherosclerotic disease, their metabolic syndrome or their diabetic patients. I think you've seen this. This was a very old slide, gosh, since 1988. So this was a paper that Rob Abbott and I did. Before then, we really didn't even have HDL cholesterol in the mix for who was going to get heart disease. And this was there was a companion figure for men and for women, as you can guess. But even at low total cholesterol, HDL cholesterol counts. We still wrestle with this, but that's the message. No matter your total cholesterol, HDL is still going to count. Now, is lower better all the way? This is a slide from a few years ago. It says 2004, but 2008. It really hasn't changed so much, except we're starting to get more dots below 55. But most of the historic trials, the earliest trials, you can almost take the year and move also to the left. So the earliest trial was one of them was the West of Scotland coronary prevention study, and then the Air Force coronary prevention study, and then a variety of studies also in Europe, and then Jupiter, which most of you are very familiar with, and then the most recent trials. This is using largely statins, as you can see in the title. The PCSK9s have moved this down, but in fact, the CHD event rates, as you see here, 4, 6, 8, 10%. The CHD event rates are extremely low. I didn't make a slide for this. There's one, Mark Sabatine just came out in the New England Journal with a review in this the last few weeks, is that we just only have 2-year studies and very low event rates and lack confidence for exactly what's going on. But we're getting, of course, cholesterol's now going down into the 10s, zeros. People like me, I actually prefer when you have a very low cholesterol not to use LDL cholesterol reporting to patients, because you can, in fact, because of error around these calculations, get an LDL of 0. And if you have an inefficient lab or an inaccurate lab, I don't know how to say it nicely, you could have an LDL less than 0 because of the calculations. So if you use total minus HDL when you communicate with patients, you will avoid that. So you reduce some of the extra calculations, but you improve your accuracy in what you may communicate to patients. What do you tell patients? Why are they taking a statin? So this one is for mortality. This is from the cholesterol treatment trialists. They've done it similar for diabetics. They've done it for all outcomes. And this one's mortality. And the number down at the bottom is 0.90. That means compared to somebody not taking a statin, you're going to do better by 10%. Now, I only put one of these slides in, but if I put total atherosclerotic disease, it's about 20 to 25%. So, Mr. Jones, you're taking a statin because it's going to reduce your heart attack risk and coronary death risk by 25%, and 10% for survivorship all by itself. So it's an easy number. That's not a comparison of high versus low. That's a comparison of any statin versus not taking it. Okay? Now, I've already mentioned a little bit the diet, 5 to 15%. Everybody thinks they can do better. It's tough to do better. We have a lot of food products that are trying to undo our efforts on a daily basis. But bile acid resins, for instance, in early trials, they were getting up 25, 30, sometimes 40%, but it's hard to take the bile acid resins. As the pills, they're big. As the scoops, nobody does that so much anymore. It's like having bad tasting Tang 4 times a day. And or Citracil, or one of these Metamucil types of products. They're just hard to get down. Niacin, and again, is one of these products. It's harder. We have now largely moved away from crystalline niacin to extended release niacin or slow niacin. You still have a potential for flushing, and that's mediated by prostaglandin D2, and you can abate the flushing by taking an aspirin, and you do better to also have foods with it. So, for instance, some patients will have on statins plus niacin. It's a common combination, but getting a lot less so because of other medications that have come along. So the cholesterol absorption inhibitors is one of them, and that's the ezetimibe. That works in the gut, largely through the Niemann-Pick receptor and interferes with that. So ezetimibe by itself is a 30% drug at the best. In combination with statins, it's a 20% drug. And then in the center, there are statins themselves, and they're 25 to 55%. If you have a patient who's failed on 1 or 2 statins, think as you go to the next one to start doing what we call microdosing and self-management. So microdosing means, I'll give the example of atorvastatin, which would be 10 milligrams a day, is you're going to use less than that. So Mr. Jones has failed on atorvastatin. He's failed on rosuvastatin. He was on atorvastatin for a year, but then he failed. What do you want to do next? Do you want to go to a third statin, or do you want to try one of those two? He's in your office. You're a cardiologist because he's at least got angina, let's say. So I still want to try, if he'll go along with it, one of those 2 most potent statins. So I'll pick atorva or rosuva and say, let's try a dose less than 10 milligrams a day. And that's up to you. So you're going to go back to something he's tried before. He may be gun shy, so to speak. He says, I don't want to go back there, in which case you may have to pick a less potent one that he's not tried yet. And you may go to medication every other day, for instance. And you may get very good results. Terry Jacobson at Grady's reported this. We've done this at the VA. You may get 30 to 40%. You're not going to, LDL lowering. You're not going to get 50%. But you're going to beat out ezetimibe all by itself. And that's important. So in fact, low dose may be by far the next step. You won't see that very much in guidelines because there's not a tremendous amount of data and it's not trial driven, but it's very effective strategies. As you can see here also, there's LDL pheresis, but then you have your sawtoothing, you're going down, and then you have to wait 2 to 3, 4 weeks, typically a few weeks, and you'll call Larry Sperling up and say, I need help. And it's expensive. Patients have they have permanent catheters. It's like a dialysis concept. And they'll also still be on medicines. And then more recently is the PCSK9. So on top of the statin where you're going to get another 50% lowering for the PCSK9. And those medications have been every 2 weeks, some of them every 4 weeks. And then there are new congener types of products that are going to go every several months. So it's getting a competitive environment for these products. Okay. Now, a little molecular biology. This is for Dr. Taylor to keep us all, remind us that this is important. So HMG-CoA works both for the production of your lipid particles, but the major effect is at the receptors. So you're upregulating LDL receptors when you're taking a statin. Most people forget to really recognize that. We also have other products. So you could use what I call supply-side lipidology. You could go very early in microsomal transfer protein with lamidopide. Dan Rader at Penn was one of the senior people developing this. These products got dropped because, think about it, if you're now preventing something from getting out on the left side of this slide, and the VLDL particles, or what you're going to get released early, get stuck inside the cell. VLDL particles are full of fat, right? So it may increase that patient's risk for fatty liver, and that's the signal that we're getting for supply-side products, and similar for mipomersen. So mipomersen is a mouthful to say. This works so that you do not make an appropriate apolipoprotein B, and these class of medications are called ASOs, ASO, antisense oligonucleotides. And more recently, it's also just being reported across the literature, is ASOs are associated with thrombocytopenia, or just mild to moderate, not necessarily bleeding levels of low platelets. And it may be a whole mechanistic class effect of ASOs. So these medicines on this side have problems with fatty deposition. Not everybody gets it, but they also can work in combination with these others. They've, especially on the left, been reserved for homozygous FH patients. And PCSK9, let me go back, I left that out. PCSK9 works as a chaperone or a whistleblower. So make sure, if you have normal PCSK9 function, your receptors will just eventually, let's say they'll do 10 cycles. I don't know the number of cycles they'll do, and then they'll quit. So the PCSK9 is what blows the signal, say, you've done your 10 cycles, you're finished, you're going to go back into the cell and get metabolized. What the monoclonal antibodies do is it says, nah, keep going. You don't need to do just 10 cycles. You need to do 15 cycles. So it ties up the PCSK9. So think of the PCSK9 with normal functioning as the whistleblower for the LDL receptor. So the whistle gets blown, the LDL receptor gets broken down. The new medications take away the whistle. So they just work over time until they finally get metabolized. But you get more mileage out of your regular receptors by working with the chaperone. Now, all of these questions have come up for what you do for low LDL. Most of them are null at this point. There have been concerns. I'll just mention one. For instance, if you're taking a monoclonal antibody, is it humanized? Yes, almost really good results with these PCSK9s. Some of the earlier lipidology with those supply side, they were not as well humanized, so you can get site reactions more problematic. You can get antibodies to these, and some of them don't work over time. What about when you get really low for lab accuracy? What should you do with your patient? So Mr. Jones has an LDL of 90, and his angina is progressing. You think he's going to get another stent, and you have him on a full dose of atorvastatin plus ezetimibe, and now he gets approved for PCSK9. So his LDLs, as you ramp it up and you get him going, you now have his LDL, and it's down to 20. And then he keeps taking it, and 2 months later you measure it, and it's 35. Should you be concerned? Well, what happened? It went from 20 to 35. I don't know what to say, because the accuracy of the lipids at that level is really pretty poor. Think about how often is he getting his shot? Every 2 weeks. Well, when you had the 20, when did you get your blood drawn versus when you had the 35, when did you get your blood drawn? You think about it? Where were you in the cycle? Because he's sawtoothing. So there are a lot of considerations when you're following these patients. Many of us would say just use total minus HDL, and you have to educate the patient when they get the blood drawn. Okay? And it's optimally, it would be fasting for these patients too. But the point is, if he's still at 35, he's still taking the medicine, isn't he? Right? And do you really need all of this detail? You understand? You don't really have, it's not like you can double up on that dose. You're on the maximum dose. So think about some of these issues as we go forward. A variety of these are going to get addressed as we go further, though, down the years, okay? All right, now this is helpful, I think, especially to cardiologists, because many of these were especially, the top I won't mention because that's what the literature shows, but not proven to reduce risk, heart failure. So if your patient has cardiomyopathy, you don't expect statin to do much for him. Right? A 60-year-old guy with cardiomyopathy, you're doing it to prevent atherosclerotic disease, but a 30-year-old guy with cardiomyopathy, I'm not sure I would be focusing on statins at all because it's just not going to have an effect. Calcified valves, big trial was done there. It didn't really do anything for calcified. What about your patient who's got calcified coronary, or got a very high coronary artery calcium score? Actually may get worse. It may make them ripen, so to speak, and they'll get more solid. So don't expect that to get better either. Dialysis patients, this is a tough one. So you have a patient on dialysis, should you start a statin? Probably not, because the trials, according to the literature. If you have a patient now with chronic kidney disease, he's on a statin, and then he's going to go on dialysis, should you stop the statin? No data on that one either. I'm not going to stop the statin. As long as he's tolerating, I'm going to keep going. So, but I actually will have patients on dialysis, and I'll put them, you have any age, if they can tolerate a statin, why not do it? Part of it is in the past because they were expensive. These are really low-cost generic medicines in most cases, but the data do not support that statins actually improve cardiovascular risk for dialysis patients. And do they save lives in older women especially? Now, don't have data on that. Why don't we have data on that? Think about it. We have to listen to people like Jennifer Robinson, who's very articulate. He says, Peter, it's because we haven't done the studies. So the studies that were especially looking for mortality benefit had many more men, and there weren't enough women in those studies. So is it true? It probably is going to be true, and we will probably see that. Whether we'll definitely have a trial, I'm not sure, but it's not been proven up till now. Dosage warnings, cardiologists need to know this because this is where cardiologists can get into trouble. As you can see there, Simvastatin, which was used in the SEARCH trial after it was published, came up with these warnings and led to a black box. And the rule of thumb, I say, if a person has active coronary disease, especially an angina patient who may be put on especially calcium channel blockers or amio, just don't give them Simvastatin. The maximum dose of Simva is now 40. It used to be 80 because of these problems. The 80 milligram dose is especially associated with a genetic variant, which occurs in about 1%, which was detected in the SEARCH trial. But in general, I tell physicians, patients, trainees, especially the patients who are at risk for atherosclerotic disease in their mid-50s, 60s plus, probably not to use Simvastatin, because the next thing you'll know, you'll think about all this, and then your colleague won't have thought about it very much and will add a calcium channel blocker. And then the person will develop cramping, won't go necessarily into rhabdomyolysis, but will have severe myalgias. So think about it. Diabetes. Do statins cause diabetes? Yep, about 10% effect. Do statins prevent heart disease? Yep, 25 to 30% effect. So you got a risk balance. That's part of your discussion when you're in front of the patient. What counts, what are the big ways to predict your patient sitting in front of you who's going to get diabetes? And Paul Ridker did this, fairly simple analysis, post hoc, in Jupiter. He says, just take the 5 metabolic syndrome traits, the glucose, the triglycerides, the blood pressure, the HDL, and count them on your fingers. Each one of those, we found this in Framingham too, is about 1.5 times. So each one is about a 50%. Impaired glucose tolerance is a big ticket, for instance. So 1.5, 1.5, that's a lot bigger than 1.1, right? So it's your metabolic burden, your metabolic syndrome burden that especially drives it. And you'll increase it with taking a statin, but it's a 10%er. So think as you have that discussion, you see your patient who already is borderline diabetic, are you going to give him a statin medicine? Sure, you're going to give him. Are you going to push him into diabetes? Might. Then what are you going to do? Well, you're going to go lifestyle and metformin. So that's a little unfortunate, but you're going to do much better by him using that strategy and not worry so much about the 10% risk for diabetes. Okay. That's potency as well. So this is across multiple studies, the more potent statins, you're going to see even a little stronger effect. All right, quickly we're going to go through the medicines and we'll wrap up. CETPs. Well, he's got 4 medicines there, and I'm not using any of them. That's right. So this was a great hope, and it didn't work out. So CETP is a molecule in the plasma. It's a genetic variant. It was reverse biomedical engineering to come up with the idea that, hey, I could increase HDL. I could take that 45 HDL that the average guy has and push it up to 90 to 100, and he won't get heart disease. And some of the molecules were developed had both HDL effects and LDL effects. And all of these were null. Unfortunately, the first one also caused hyperaldosteronism. The others don't do that, but they don't work. Now, the only one that's a sort of a viable thread on this right now is you can see under dalcetrapib. There's a DAL gene trial. Within dalcetrapib users, they found genetic variant, which was associated with better risk. And I believe our colleague, Kriton Mavromatis, is one of the investigators. He was, for sure, was on the DAL outcomes trial, but that's a follow-up trial that maybe used some genetic testing in concert. But in general, all of these have been null. one was positive, but they decided it was going to have such little effect with the PCSK9 coming along that they abandoned. So, all right. What about PCSK9? Now, I know it's hard not to hear a talk about every 1 or 2 months, but who gets PCSK9? Heterozygotes, as you see down there, homozygotes, and then this last bullet. We're going to get a new set of guidelines at the heart meetings. So one of the major questions is whether any of these bullets will be revised, especially this last one. Clinical atherosclerotic cardiovascular disease, such as heart attacks or stroke, who require additional lowering. Now that's rather fuzzy, isn't it? So let's say you as a doctor provider decide the patient needs additional lowering. The bigger issue is whether the insurance company agrees with you. So, and so that's been a major challenge. In the VA, we do not have that. I have to convince the pharmacologist. And so the cost of these medications was $12,000 to $14,000 a year. We have two of them available right now. And then with the recent Odyssey outcomes results, they were cut in half. So we're waiting for the Odyssey outcomes to be published. They were presented at the American College of Cardiology, and hopefully they'll be out soon. Now, I did this. Others have done it more elegantly, but I've used this slide in a few places, is to estimate if you were trying to figure out where to put your money, so to speak. How do we approach this? I want to think about all these different terms. I want to think about how long a trial goes, the relative risk, the risk reduction, the number needed to treat, the cost to treat. Here I have the 2017 costs. I should be updating that. And then the cost per event prevented. And you look down there at the bottom. So the last three on the far right. So Odyssey outcomes, which was presented at ACC, $750,000. Osler trial, almost $1 million. Fourier, $750,000. Okay, well, we'll cut the price in half. It's still big money compared to these others. And then also then look at the number needed to treat. So WASCOPS with a number needed to treat of around 40 was statin versus no statin. The bottom of this, like Odyssey outcomes, Osler and Fourier, is statins already on board, the number needed to treat for everybody's already on a statin. As you can see there, it's over 50. So this means all of your patients. Now, well, then who's going to get it, and is it cost effective? It's clearly going to benefit some people. It's a question of how we move forward. And cost, interestingly, has historically not worked its way into approvals. And not so much, well, it did indirectly in the guidelines. The current guidelines group, and Larry Sperling's in the room, we got to ask him as we finish what he can tell us as a leak, what he thinks is shareable for the next month or so. But cost has historically not been there. But one of the things for sure, in the current version of the guidelines that's coming forward, there is a cost group. There is definitely going to be a little bit more concern and attention paid to it. What about immunotherapy? So Dr. Ridker, Paul Ridker up in Boston, has been the CRP advocate for many years, and that's translated into two trials. The CANTOS trial, it's easier to say CANTOS than the interleukin-1 beta receptor. That I can say it, canakinumab, but it took practice. That was published fairly recently, decreased relative risk, decreased CRP, no effect on lipids, increased fatal infection, and interestingly, decreased risk of cancer. But it's extremely expensive. This was a proof of concept. This is multiples of what the PCSK9. And then the chronic inflammation reduction trial, which is a statin plus methotrexate at low dose, and the dose is titrated. That result is expected to be presented also at the heart meetings in the next few weeks. All right, that's the same thing. All right, we'll wrap up here with triglycerides. Over on the, just for some naming, so on the far left here, we have xanthomas. They look like little pebbly xanthomas. Those are eruptive xanthomas. They may burn or itch. They go along with high triglycerides. This is sort of on the forearms, elbows, or you can see them on the knees, on the buttocks, on the back. You may think that the person has a rash. On the next slide pattern there, that's lactescent serum. Lactescent, that left looks like a pink milkshake. That is that's probably a triglycerides of several thousand. To get there, you probably have to be over 1,000, and then the right is a normal one. The most common person to have a reason to have lactescent plasma in the lab, I always ask the endocrinologist this, and they say, oh, I don't know, doctor, what's this? It's diabetic ketoacidosis. This is what their plasma looks like when their triglycerides go way up and they're in DKA. Far right is lipemia retinalis. So the arteries and the veins don't necessarily look quite as distinguished because everything's got a lot of fat in it, and then look more yellow-orange. These are tuberous xanthomas, go along with hypertriglyceridemia. And then you can also get palmar crease xanthomas, and it's mostly just yellow lines that you see along the palmar creases. Okay. Determinants, just focus on the right side. Heavier patients, more saturated fat, diabetes, as I mentioned earlier, greater alcohol. Not everybody gets this. And then some women taking estrogens get high triglycerides. For a woman, for instance, on an oral contraceptive or perimenopausal estrogen, it would lead to changing the estrogen dose and working with a gynecologist to reduce the triglycerides. One of the common places where the highest triglycerides in the hospital, if you happen to measure it, other than alcoholics and pancreatitis, is third trimester of pregnancy. So those of us in lipidology, we actually don't encourage physicians, gynecologists to measure it because they're going to get concerned because they're very high during the last trimester. So, these are the definitions. You can quickly see, but very high is over 500. And etiologies, especially genes and environment, and we have more and more genetic variants coming through, and lower fat intake, and then the types of fat. I'm not going to go through this, but Michael Miller, 2011, American Heart Association statement of how to approach it. As you can see, they get concerned, especially with these guidelines above 200. I'm going to make sure we get through here. And what do you do to reduce these? Reduce alcohol intake, weight reduction, and saturated fat. And then there are the medicines. So the first medicine to think about is gemfibrozole or fenofibrate. There are some other fibrates around the world, but those are or fenofibric acid, which is very related to fenofibrate. But these are the two that we have here in the States. Niacin as well. Niacin will really knock down your triglycerides. And then omega-3 preparations. So omega-3 comes in two groups, the EPA and the DHA. You'll have patients who will say, I'm taking omega-3s. I'm taking fish oil. I get them at Target. And you should tell them to bring in the product. It's an over-the-counter product if they're getting it without a prescription. You're not absolutely sure. They're probably only taking 500 to 1,000 milligrams per day. Not much. Pharma dosing of omega-3s is 4 grams a day, and these are big green jelly beans that taste like fish. You can reduce the side effects. I'll get to that in a second. But most patients who say, I'm taking it, they're taking just over-the-counter levels. So I'll skip by this. I think you're very familiar with the fibrates. Let's finish up though with the fibrates. So there have been early trials with fibrates. They did prevent heart disease. In the statin era, the issue is adding statins. You already have statins on board. If you add a fibrate, do you get more benefit? That was done in a Cohort, and it was only a subgroup. Okay? So let's see here. This is what I wanted to show. In field and in Cohort, there was 2 subgroups that said low HDL, high triglycerides. So everybody's getting a statin, low HDL, high triglycerides, I'll add on a fibrate. And a Cohort altogether was a null trial, but that subgroup did benefit. All right? And that's why we've got what you see down here at the bottom. Is the prominent trial that just the VA is recruiting for this. Dr. Ridker is the overall PI. This is a drug that you've not seen yet, pemafibrate, 10,000 person target. MACE is going to be, and it's just getting going. It's going to be at least 4 to 5 years to address this, okay? All right, now come back to omega-3s. So those are the full spelled out names The dosing, as I was mentioning, so if you have a patient who's especially over 500, especially over 1,000, they are candidates to get fibrate plus omega-3, okay? So they can get fishy taste. And they say, gee, Dr. Wilson, I really don't like this. So one of the things to do is to take the pills that you're going to take tomorrow and put them in the freezer. And then the next morning, each morning, they're swallowing frozen omega-3 pills. So you won't get the fishy taste because it's frozen. That helps some people. Some people don't mind, but some people really does make a sense. You will get belching for most patients. There's very low risk of bleeding, as you can see here. And then coming down historically, where have these trials been positive? Why are we talking about these so much? Well, one was the Japanese study, the JELIS study, which was a low-dose statin, and I mean low-dose, like Prava 10 type of levels, and that Japanese generally have been using lower dose with only 1,800 of EPA. And then GISI, which was an Italian study, only no statins on board at all, and low-dose omega-3s, polyunsaturated. So now where are we? We've got these trials, okay? So as you can see down here in the bottom, Reduce It is positive, as a matter of fact. So they released a press release that it's a positive trial, starting with triglycerides 200 to 500. It prevents ASCVDs, already on patients all already on statins. There's another trial, Strength, which has not come out yet. Now, MACE was reduced 25% in Reduce It. Many of us want to see how much it's going to reduce heart events, not full MACE. This is an extended MACE, included angina admissions. So I think that's going to be critical. So we may have some game-changing. We're going to have several of these trials presented in about 3 weeks at the heart meetings. Okay, and that's the last slide. Those are crystals of cholesterol. They look like little houses with rhomboids with another little rhomboid on top. Okay, thanks.
Thanks, Peter. That's great. We have time for a few questions. I'll start off with one. And you mentioned the data about statins and patients with high calcium scores. And so, how do we navigate that then? What's your approach to those patients that come in with a sky-high calcium score, no obstructive disease, no events, and the data aren't there for progression, right?
Yeah, so you have to focus on your clinical outcomes for your patients. And the other is, how much does a positive calcium score change your thought about your patient? So that's rewording Bob Taylor's question. And the best data come from the MESA study, which is an observational study. And they focused on people at intermediate risk. And then they already had the calcium scores done, but then they tested how much that might change risk at intermediate risk. For instance, they didn't do it with the most modern intermediate risk, but let's say 5 to 7.5% 10-year risk. And that's where it increases your risk tremendously, 25%. So it's a big winner at intermediate risk. So you're going to have your patient, let's say Mr. Jones comes in and he's got most of his risk factors not too bad, and you go ahead and you order a coronary artery calcium score, and the number comes back definitely elevated. And then definitely elevated, we got Spencer King in the audience, so he's going to have we have true expertise, but in the guidelines, they generally have historically said 200 or 300. But that's enough to really move that risk up another 25%, okay? The other point to come back to for CAC score, because indirectly he was asking about CAC score, how do we use it? If your patient has a CAC score of 0, that's also very helpful, because that person really has a lot, his risk gets a little bit downgraded because of the CAC score. But do not expect the coronary artery score to improve. That's the point. It just doesn't improve.
Questions from the group? Well, I'm going to ask one more then. So with the statins, so one of the things, patients ask you about all the time is the cognitive stuff, and we go over and over and over again that there's nothing to that at this point. And then the diabetes issue comes up, and the argument you presented that we understand is great, but it's hard for patients to sort of grasp that. And so I have a patient who's a scientist who says, well, if you can tell me the mechanism of that, then I'll understand it better. And so I don't know that mechanism. So why does statins increase your risk for diabetes?
We still don't know. No, we still,
supposed to know. You're an endocrinologist.
we still don't know, and it's really only 10%. If you have a fasting glucose of 100 and diabetes is 126, each one of those is a 1%er. So that's 25%. Your fasting glucose alone, right in that narrow range, is very important. But so is your body mass index or your waist girth, whichever one you want to use, your HDL, your triglycerides, and whether you have hypertension. And those are much, much bigger, just much bigger. And the best place to see that really is the Jupiter trial post hoc analysis. Yeah.
Let me ask you one question about that. Are there certain patients whose blood sugar goes up, and that's just a population, or does it go up in everybody a little bit, and some of them get above the threshold?
Yes.
In other words, if you didn't take statin, your blood sugar might be 95, and you start taking it, it goes to 102. Is that what happened?
Very fair, Dr. King, but as well, there was a post hoc analysis done for the fasting glucoses in the niacin trial, the original coronary drug project. There are also some people who goes up and then it settles back down. And the other is mild diabetes is highly treatable, really highly treatable. Entry-level metformin will probably cover these patients. And so let me mention one last thing about metformin, because you might not, cardiologists for sure haven't seen this recent literature. So metformin, very recent studies are suggesting that the tolerability of metformin at decreased kidney function is greater, which means we used to stop at like a creatinine of 1.3. You can probably go up 1.3, 1.5, and you're going to start to see algorithms probably talked about in the literature. Maybe I give a talk about diabetes later in the year, we'll go into that, is that rather what you're going to do is you're going to take your diabetic patient taking metformin at 2,000 milligrams total a day, and as his chronic kidney disease is deteriorating, it's getting worse, you're going to work him down close towards 500 milligrams per day. And it's going to be a medicine we're going to be able to keep using, because we have to move so many people out of it because of progression into CKD. But many of us have felt that, hey, it's pretty easy to add metformin. I think in cardiology and preventive cardiology in general, people haven't felt that, but they probably should. The very mild diabetes, especially with the burden that we have obesity in our society versus clinical coronary disease, it's very easy to treat. So.
Okay. Well, with that, thank you for a fantastic talk. That was great.
The preceding program is copyrighted by Emory University.